Hi, welcome back to Live from the Global Spine Congress in Las Vegas, Nevada. I'm pleased to be joined by two very distinguished individuals. I'll first ask you to introduce yourself. Tell the audience a little bit about yourself. Greg?
Sure. I'm Greg Schroeder. I'm one of the spine surgeons at Thomas Jefferson University Hospital in Philadelphia. I take care of a lot of patients with spine trauma, and I'm fortunate enough to be on the steering committee for the AO Spine Trauma Knowledge Forum.
Klaus?
My name is Klaus Schnake. I'm an orthopedic spine surgeon from Erlangen, Bavaria, Germany. I'm the head of the department, and I have the honorable job to be the Knowledge Forum Chair Trauma.
Great. So I hear there's a bit of a controversy here. So I'm going to turn it over to you, Greg, to set the stage for the controversy for our audience here.
Sure. So one of the big questions that we have in spine trauma is whether or not we should operate on these A3 and A4 burst fractures. And one of the great things about AO Spine is we are actually in the process of doing a prospective study where we should be able to hopefully give the results to this by our Global Spine Congress in Prague. So we're really excited about that. But there's really a big disparity right now with North Americans like myself saying that we should basically operate on none of these or very few of these, and other cultures such as the Germans operating on a whole lot of them. So I'm going to ask Klaus, why do you operate on a neuro-intact burst fracture?
Why shouldn't I? I mean, the idea is, to get the patient as quick as possible out of the bed, become mobile, treat them without any orthosis, and get them back to work or whatever activity they had before. So although we know that's a of course it's invasive to operate, but we think that's the way, to achieve a sustainable result, plus getting the patient very quickly, as I said, again, back to work or back to daily activities. So for us, it's more or less clear that at least complete burst fractures get operated on.
As an impartial person, that makes a lot of sense. Greg, see if you can make as much sense.
Sure. I mean, I agree with Klaus that I do think that if you operate on burst fractures, they are able to get up and get moving and mobilize. My comment would be that I think there's a lot of morbidity that comes with surgery, right? Every time you make an incision on the skin, you can have bleeding, infection, all of these complications. And that's basically what Kirkham Wood's study from the 1980s found, was that the complication rate of operating on these patients is pretty significantly high. And so if we can maybe not get them back to work quite as quickly, but completely limit our complications, because there just really aren't a lot of complications from putting somebody in a brace, then I think that you're decreasing your rate of complications, you're decreasing the overall cost to the healthcare system. So I think you can treat the patients and get the same long-term result with a brace as opposed to surgery.
So that also makes a lot of sense. Klaus, why does not make sense to you?
Well, because we do not operate any longer like in the 80s. So, treatment has changed. And I hope, I think you have some more, I would say, modern or latest techniques available.
Alex still operates like it's the 80s, but I don't.
Okay, so no, just kidding. No, well, of course, complications are an issue. But today, our treatment is totally minimal invasive. So there are very few indications where we have to make an open surgery. And these are typically the ones you operate on as well, like the C-type injuries.
For sure.
So the translational fractures. But the burst type, they come in the day of they come in the casualties, we check them, we make the CT scan, whatever, and then they go more or less right away to the OR or very soon and make a percutaneous fixation from posterior. And then they are set. And in some cases, then additionally, we think about an anterior stabilization. But even this we can do today through a thoracoscope or at least with a mini thoracotomy. So that means we are fully minimal invasive. And what all the minimal invasive studies showed over the last years is that the complication rate is definitely lower than if you compare it with an open technique. So I totally agree. Open surgery carries a lot of risk for complications, huge scars, etc. And then the patients, it take longer for them to recover. But minimal invasive, they get up the next day.
Now, do you then go back and take out the hardware? Because one of the concerns that I have about a minimally invasive percutaneous fixation here, right, is they're probably not going to fuse. Well, if they don't fuse, then they're going to have loose screws. So now you're talking about another surgery 6 months, a year from now that you got to take out, which is your argument to get people up and moving faster, but now you're going to do another surgery a year from now is going to kind of set that back.
That's a very valid argument. I mean, definitely we have to see what kind of fracture it is. And of course, let's say a fracture with not that severe comminution, where there's a chance that it heals on its own and the disc is not that destroyed. Of course, then we consider a pure posterior stabilization, no fusion, and then, yes, typically about 6 months later, we consider taking out the implants. We do not do this in all patients. If the patient refuses, we don't do this. But in the other patients where we see a really high degree of comminution, so a destroyed vertebral body, our protocol foresees that we then go a couple of days later through a minimal invasive approach anteriorly and make a fusion. And then there's no need for taking out any implants in the long run.
Definitely there's no need for taking out the implants then, but then I can't imagine that person gets back to work faster than if I had a brace. If they were perc screws in the back, 3 days later, a corpectomy in the front versus a brace and going out. So I think that this is one of the most fascinating things that the AO Spine Trauma Knowledge Forum has done, and I think we should really commend Marcel, who has done a great job, and I can't wait to see the results of this, because I think that, like Jeff said, right, what you say as I'm sitting here listening to you makes 100% sense to me, and it makes me convinced that, gosh, I should be taking all of these people and putting in screws. But I also see in my patients that I give them a brace and they come back at a month and they're back and living their life, and I wonder, like, am I missing something there? So I think that the Equipose study and the A3-A4 study is going to be great to kind of hopefully give us this answer.
Yeah, actually, that's why we performed the Equipose study, and that's why we performed the study, the TLA3-A4 study at all. I mean, to figure that out. I mean, for sure, after a year or even in the long term, the results are the same. So when you have time, the results are the same. So there's definitely no 100% need for surgery. So if the patient has time, you can treat them conservatively and wait. That works. The question is, as a matter of fact, and we don't have data about this yet, what happens after 3 months? As you said, are they all fine after 3 months? Do they go back to work? How long do they take the brace? And what about when they treat them surgically? Of course I can say they go back to work, but I have to prove it. So what we actually need is kind of, what are the short-term outcomes? What is the return to work rate, and when? So
totally agree.
That's I think today is a very important aspect, because people need to go back to their daily activities soon. And the older they get, the more important it is, because if they lay down for a long time, they get DVT, etc. So I think these are the questions we have not answered yet, but hopefully we'll get more information out of the study.
So you bring up a great question, the older patients, right? So these are the ones that I also really rack my head around, right? Because if they have an osteoporotic burst fracture, to me, it's not the same as if you got a burst fracture. But by the same token, these are the people who hardware fails in, who they really fall down. So I think I look at them, and I'm still treating all of these people, maybe not even in a brace, and they're definitely collapsing down into kyphosis over the next 6 months. But they're collapsing down into kyphosis. I feel like if I put screws in, they're just coming loose, and now they're pulling out, and I'm having issues. So do you treat the osteoporotic burst fracture? Like, that to me is like, I'm really not operating on this person. Would you treat an osteoporotic burst fracture the same way, or is this just like a 45-year-old healthy worker?
Of course, they're not the same. You're right. Definitely. Well, one goal is definitely that they have to get out of the bed as soon as possible. So here, time is really is a really critical point. So when they are bedridden and when they do not get out of the bed after a couple of days, when they are in such a severe pain, and if this fracture is obviously so unstable that they have mechanical pain when they get up, we consider surgery, just to get them out of the bed. But then, as you said, the problem may begin. So of course we can do everything percutaneous. That's a good thing. So it's a minimal invasive surgery that's suitable for the elderlies. However, what about purchase of the screws?
Right.
Okay, we augment the screws with cement, with PMMA, etc. But then, there's always a risk of cutting out of the screws, of implant problems. So yes, we still have some unsolved issues. But over the last years, the so-called hybrid stabilization, that's a typical bisegmental cement augmented percutaneous stabilization, either with index screws in the fractured vertebral body or with a kyphoplasty or vertebroplasty in the index level, has become a kind of working house in our environment. So this seems to work quite well as an alternative to kyphoplasty or vertebroplasty in that patient. So these vertebroplasty, kyphoplasty, plus the short, very short percutaneous stabilization are our, I would say, are our tools.
It's just interesting to me because I feel like America gets like, you know, we're so expensive for medicine, we do everything, and here we are, and I'm telling you, listen, I'm putting them in a over-the-counter brace that should cost $80. I don't know how much it costs.
It's probably a lot more than that.
It's probably a lot, yeah, it's probably $1,000, but it's probably less than a single pedicle screw. So it's just an interesting thought that, like, in general, I always think of the Americans as being really aggressive, wanting to, you know, with our healthcare, go forward, go forward, go forward. But here we are sitting here and we're kind of getting the opposite answer. So it's just it's interesting. But I would still tell you that I think I would put these people in a brace. I think if I put them in a brace, they're going to be fine.
So, you know, to conclude, you know, we are working on this in the Knowledge from Trauma. So that means, yes, exactly. Our next project are osteoporotic fractures. You know, how do we treat them? How do we classify them? So we will probably come up with some answers soon. So follow us.
So I would say that next year in Prague, we get the two of you together and revisit this debate with the new data.
Definitely, it would be a pleasure. Thank you.
Hopefully there'll be consensus next time.
Absolutely,
Because we follow the literature.
There may not be a need for this next year, but
Exactly.
Thank you guys so much for the lively debate, and we look forward to Prague to find the real answer, to see who was right. We'll record this and replay it next year to see who is right and who is wrong. With that, I'd like to thank you for your attention, and we'll go ahead and conclude this session.